Good afternoon, and thanks for having me. My name is Mike Turon. Uh, from Surgical Navigation Technology. I've been working in the field of IGS for about 18 years and been involved with IT for about 30 years. When I was asked to talk on image-guided surgery and where it fits in the clinical environment, it was an interesting point for me because for the first time it's really become quite a difficult placing of that technology in the hospital environment. And so what I'd like to do is talk about IGS and how it's fitting in from the starting point of where we know the clinical environment and how we're used to the clinical environment. Look at the playing field and see where we've come from, and from there get an idea of where it's going. And specifically in the digital environment, one looks at the networks that are involved in the hospital environment and the flow of information. And the easiest place to start and look at the movement and capture of data within a hospital environment is pretty much at your patient admissions. And one of the earliest networks that was out there was the pneumatic tube system that was found in a lot of hospitals, where these capsules were sent round by the press of a button using air, and they could deliver reports and samples and things throughout the hospital environment. And many hospitals still use these, funnily enough, today. So there's a large volume of data that has to move around the hospital, sometimes covering major distances between different buildings, different technologies, different types of data being either reports or bloods or scans or you name it, various different types of information that have to flow back and forward. There's also quite a load on record keeping because it's physical. In the older days, it was physical paper that had to be kept, huge filing cabinets and rooms and storage environments that had to be able to keep this information and then be able to retrieve this information as and when it was needed at the point of care. Things like patient scans, if patients took their scans and went off and lost them, well, there was no way of getting those back. You'd have to rescan the patient, re-get their x-rays, re-get their films, things like that. The one place you'll see where the first data capture bottlenecks happen is at the patient admission location within the hospital, and often there'll be queues and rows of patients trying to wait to be admitted. And obviously this is your ultimate determining factor for the hospital going forward, and that is low patient satisfaction, which is not going to reflect well on the system. And as I said earlier, various types of data flowing around the hospital. We'll look at the different types of data in more detail as we go on. And then, of course, access to this data. Who can see what, when, where, and how? In the older days when patients' records were just lying around next to their beds, their families would be reading it, people would just be accessing. It was easier to access data, and I don't say it's no easier today, especially as the networks and things get more and more complex, so more and more data is moving around these environments. You've got to look at what to put in place to be able to ensure that this data doesn't get into the wrong hands or become public knowledge. One of the first places where data was moving around hospitals was patient imaging. One of the biggest types of data acquisition was patient scans, and you'd have to have special viewing rooms that had light boxes in so that surgeons could put these scans up and be able to look at them and analyze them and plan and ultimately use those images to plan their surgeries. So it's the most basic form of image-guided surgery, really. But the problem with these early imaging systems was that you had large image processing equipment, chemicals, films that captured the images, that had to have dark rooms where they could process these images, and then the films had to be stored and carried around, and there were even, as I said earlier, locations on the patient's bed where these images could be stored within the bed. We mentioned light boxes had to be in all the locations, or you'd even have a surgeon holding scans up to a window to try and see what data he needed to in order to make an assessment. As mentioned earlier, large storage requirements for all these different types of films. And collaboration not easy because you'd all have to be at the same place where those images were. If one looks at the early days of planning for orthopedic procedures as another task, which was then a requirement for images guiding surgery, case planning and preparation had to be done. So scans would have to be done. There would have to be some sort of sizing on those scans. You can't start to do measurements on scans unless we know a scale that we can start to measure against. Then the surgeon could spend a whole lot of time doing geometric calculations based on those scans, measuring, templating, sizing, trying to find the best match to a catalog that he has of parts that he could use to then go into theatre and try and put those into a patient. So a lot of planning involved, a lot of planning time, possibly a lot of theatre time, because you may not have the exact implant that he needs, and so you'd have to re-template and replan in the theatre environment as well. So very time consuming. And those, just looking at those two simple things, viewing images, and then of course here viewing images to plan, we're going to now step on and see where those two items have become digital and are now taking presence in the clinical network environment. The DICOM Viewer is the most basic form, to me, of image-guided surgery system that one will find in a hospital environment. What it's done is it's allowed the surgeon to take anatomical scans of patients and view them on most PC-type equipment that he can find within the hospital environment. He's using straightforward 2D scans in 3 different planes, which can then give him a location in 3D space. And it's the most, as I say, the most basic form of image-guided system that the surgeon can load these scans up. By looking at the scans, it gives him an idea of what he wants to do, and he then has to correlate that theoretical model in his head to the actual model on the patient. But he's still being guided by the images and what he can measure and calculate upon those images within the DICOM Viewer. As the DICOM Viewer is getting more and more advanced, and so we're seeing it in more and more theatres on more and more devices, so the 3D option is starting to come into it, where systems can start to now build 3D structures, be they skin models, structures within the patient based on their anatomy. As we saw earlier, also we spoke about digital planning, orthopedic procedures, and so with the planning for these orthopedic procedures, where it was very time consuming and surgeons were having to do a lot of physical calculations, that whole thing has now become a software application where the sizing plates can be put on and a patient scan can be acquired, can be loaded into a computer system, and the software will analyze and make corrections, and the surgeon can manipulate those images to correct anything from fractures or deformities or anything along those sort of lines. He has the ability to measure and template upon those images, and once he's done that, he then has access to a digital template library of every single manufacturer that's out there. Every single part that's made is sized and coded digitally. He can then select the exact implant that he needs for surgery, size it, template it, see what it looks like within the images, and then proceed to surgery, order the correct part in, saves him a lot of time, a lot of theatre time, preoperative planning is done, and the intraoperative planning should be minimal. And what I think next is to look at the types of traffic then that are starting to flow within a hospital environment. So moving on from those old pneumatic tube systems to the digital networks that we're seeing today and the type of information that's flowing across those networks. And that can be anything from DICOM type images, which is to do with patient imaging, hospital information system traffic. It can be a messaging type service. There could be video moving across the network. There could be asset management software running from a head office level, monitoring all your assets, managing those assets. Digital planning for workflows moving across the network, scheduling patients for theatre, scheduling what treatments, what drugs were used on those patients within theatre, linking that to billing systems. Of course, you've got your image-guided surgery and your computer-assisted surgery, two different technologies that kind of fall under the same banner. And then, of course, media capture, storage, streaming, as I said earlier. So there's a lot more information traveling across the hospital network today than there was a good few years ago, and it's only expanding bigger and bigger. The big challenge on the hospital network today is speed, obviously, and security. What used to be a 100 megabyte network a few years ago that we all thought would never need any more capacity, today I don't think your bottom end fiber type networks will handle the requirement in a full enterprise hospital environment. And you'd have to have state of the art equipment that can handle the requirements as we'll go into them. And linked to that, of course, is security. More and more cases are coming up where educated people who have the ability to hack software applications are starting to do some things that get them into serious trouble. There have been guys that have hacked entertainment systems on airlines. There have been guys that have hacked big industrial systems and caused them to overheat and melt down. Hospital information systems, hospital networks are going to have to be secure enough that people can't sit in that environment and hack them or get access to information that they shouldn't, or patient records that they shouldn't, or patient images that shouldn't go public. Who's accessing those images? Everything like this needs to be considered in the digital network environment. The digital hospital. Completely reliant enterprise type environment that uses this technology to leverage better quality of care and ultimately greater patient satisfaction equals more business. It's a streamlined environment. Processes are streamlined. Its designs are streamlined. It's a real-time enterprise environment in that it can be controlled in a central location from a head office level that has access to all these hospitals that sit out, can be countrywide, can be worldwide, and they have access to their networks, access to information, access to assets. Complete real-time environment that allows enterprise monitoring and management. There's an increased demand to maintain these processes and innovations, and that's quite a load on the digital hospital, but they have to maintain it. They've got to keep up with the technologies. All this in an environment where there's a rising cost of skills, rising cost of the workforce, and of course the cost of these new treatments and technologies to implement them, to maintain them, to service them. It's not a cheap environment to run. They have to provide the innovation that's required to perform better diagnosis, better integration of systems, and ultimately produce a better result for the patient and better patient satisfaction. If we look at the digital environment itself, in a theatre sort of location, there can be anything from, we touched on them in a protocol type level earlier, but now we'll look at them in a little bit more detail. So there can be patient monitoring, reporting and tracking, and that can be anything from monitoring the patient vital statistics to tracking and reporting, as I said earlier, what gets used on a patient in theatre from a billing point of view, to even tracking where the patient is within the theatre environment, clocking systems that automatically start billing processes and stop them when patients leave and enter certain locations. Then there's the patient imaging and diagnostic type system where images have to be moving around. They've got to have places where they can be displayed, viewed, manipulated, reported on, added to. There's the movement of this patient data around, so you may be capturing images within the theatre. You want to store that with the patient's files and store that in another location that can be then retrieved at a later date. There are messaging and alert systems traveling around electronically now, the integration of messaging system into all these devices so that communication can happen in real time. The device integration and interconnectivity is getting more involved. Microscopes are starting to talk to navigation systems. C-arms are starting to talk to navigation systems. There's an interconnectivity of all these devices, and that also creates network traffic. There's the networking of the general networking of the hospital. There could be video conferencing up to a boardroom or externally to bring in a mentor type scenario where a video conference needs to be made externally. Then, of course, as mentioned earlier, from an enterprise environment, there could be asset tracking and management software running throughout the network. There could be clothing tracking and monitoring with the advent of RF type tracking technologies and the cost going down and their technology increasing to the point where they can be attached to clothing and still go through washing systems. There's RF type tracking of clothing. There are more and more advanced waste handling systems, intelligent waste handling systems that move waste and deliver it to the right location in the right way at the right time type systems. There's automatic transport and delivery type robots, which will drive around hospitals and collect or deliver whatever's required of them. Then, of course, I think as the future comes on, so we're going to see digital terminals start appearing throughout the hospital. Terminals for patient information, for patients' entertainment, things like that. And then, of course, that linked to digital signage, digital displays all around the hospital. And then, of course, intraoperative imaging, scans being acquired at the time of operating, new data flowing across the networks at those points. Also additional traffic that's coming into this environment. So the load is quite heavy in the digital environment. The demand is increasing not only for the amount of data, but for the type of devices that this data has to be viewable on. Users want to view anything from their PCs to their laptops to their iPads to their cell phones. The interfaces are growing exponentially, and the digital environment is going to have to be able to keep up with this. The size of data is starting to increase. What was a large file in days of old, call it a 50 meg or 100 meg file, today can be a 3 or 4 gig HD full video recording of 20-minute type procedure. Can the systems be in place that can handle that sort of data? Remote access is on the up, not only for viewing and accessing hospital information, but as I mentioned earlier, video conferencing, mentoring, training, all those sort of things are increasing. The days of having a full complement of staff go and attend a training course are getting less and less as productivity has to be on the increase in this day and age. So users are doing training via internet, remote training, logging onto sites, things like that. And of course, as I mentioned, mentoring and best practices, collaboration, having multiple users access a specific environment to collaborate, to plan. This is all going to start increasing, and obviously all influences the amount of traffic and the amount of data that the networks can handle. The challenge, of course, in this digital environment is to deliver and receive the correct information in the required format to the relevant person at the right location, in the right time, in the easiest manner. And something has to be able to deal with all this information flowing around. They're all different systems. Not every system talks to every other system. The integration of all these systems is going to have to become unified so that at the point of care, the relevant person can get the required information that they need and make the decisions, etc., that they have to. There are a lot of systems spread throughout the hospital of different technologies that need to speak to different users, different other pieces of equipment, different pieces of software, and they don't all speak the same language. And so you get this mismatch of different communications channels that have to happen, and ultimately it starts to look like a bit of a spider's web because the lines start to get blurred. Ultimately, what the hospital needs is a product that comes out of the BrainLab stable, which is the BrainLab proxy server. And this is a piece of software that can sit in the middle of this network and speak to every device and put that in a language that then needs to be for the device that the communication needs to happen with. It converts information from what it's receiving to what is required for the other communicating party. And so it becomes this communication channel that allows all systems to integrate with one another. And that's the BrainLab proxy server. The proxy server has software that runs on it that starts to do intelligent management of information within the digital environment. And if one looks at the world today and the evolution of the world, they speak about the Industrial Revolution and how industry put so many men out of jobs. Well, the software revolution is only beginning, and that's going to put even more people out of work. Because if one looks today, the biggest hotel group in the world, as they're quoting, is one that doesn't even own a bed, and that's Airbnb. The biggest taxi company in the world that doesn't even own a vehicle is Uber. It's all software driven, and software is going to be the future of this digital environment. Let's have a little bit of a look at what we call our preprocessors and the software that would run on that sort of proxy server. What can happen is that software apps can start to pick up work lists. So the software would see a work list delivered for a theatre for the next day. On that work list would be certain patients for certain types of procedures. The software could then go and prefetch late at night, while the networks are quiet, all the information that's required for that image-guided surgery procedure in theatre number 1, and prep it in a way that it's preloaded for the surgeon's preference. So it can automatically build models for him. It can automatically build structures of what's required for the procedure, and it can also start to intelligently start to pre-plan, predefine what it can reference based out of external data to the surgeon, and that when he arrives in the morning, everything is prepped for him in the theatre that it is required, so it doesn't require this rush of network traffic first thing in the morning. Everything's ready in the location where it's needed. Surgeon can do his procedure. He can then conference in other users, whatever's required of him. He can add information to it, the data that he has, and then place it back in the environment that it's required. These software applications would do a lot of planning for the surgeon in this environment. They would preload certain images, merge those images together. As I mentioned earlier, they could reference what it's seeing within the images to external databases that build as patients get treated around the world. BrainLab gathers information and starts to build this library of information that can be used as a reference tool to come back and give the surgeon guidance, external reference to the treatment that he then has to perform. Structures can be built, and if you look in the top right corner here, you can see the fiber tracks of the communication channels within the brain have been built. The telephone cables, call them, of the brain, the DTI fiber tracks. Those have been overlaid in the top right-hand corner of that image into the microscope ocular, so the surgeon's seeing this graphic over what he's seeing as a real live video feed, and he's able to make a better assessment based on what he's looking at. All this sort of pre-processing is going to start to happen more and more within the clinical environment, and all this referencing externally to external data is going to happen more and more. So the surgeon's not only going to be making his decisions based on this specific patient data that he's now looking at for his specific case, but he's also able to reference external information that will come based out of databases that are just growing and learning and building all the time. And this is the beauty of the BrainLab environment, is that it's just continually growing, continually learning, continuously gaining more and more data that it can then reference back ultimately to the physician to make a more informed decision. So ultimately all this information comes together and then gets presented to the surgeon within the clinical environment. And so in the operating theatre, he can operate using either an optical or an electromagnetic navigation system that then takes his instrument of choice, and based on that instrument's location in space can reference him like a GPS system does to where he is on the patient's preoperative anatomical images. You can then take those images and not only have to display them on a navigation system, but integrate them into the ocular of his operating microscope, so that he doesn't have to look away, that he doesn't have to look externally for additional information, that this information can be injected into his ocular. The requirement then becomes that as he so resects a specific lesion, let's say, he does not get updated information, updated data, updated images. So now we start to integrate to other images devices within the OR environment. And so, as you can see there's intraop imaging and there's integration to an ultrasound Doppler. And so the ultrasound probe can be brought in. Tumor could have been resected. New images can be acquired with the ultrasound Doppler. And a correlation is made between the ultrasound images and the preoperative images. And so the surgeon gets an updated data set which now says, okay, you've resected so much tumor, there's so much is left. Or if more detailed images are needed or more advanced technology is needed, then you can have something like an integrated CT environment, intraoperative, so the patient with his cranium open, can be placed into a scanner in the theatre environment, new images taken, residual tumor can be visualized, and then of course coming back to the full offering of the brain lab environment with something that they call adaptive hybrid surgery, software can start to make recommendations of what it's seeing in those images based on the treatment that has been done to a point, and then start to give the surgeon multiple options of his treatment going forward from that point onwards. Ultimately, the surgeon would use these technologies to either perform a biopsy, as can be seen there with an image of the BrainLab Vario Guide biopsy system on the top left. This can be used to target a location intracranially for a biopsy of a lesion, completely guided arm that just has some adjustments that need to be made by the user to align it, and then it can target a location. Or the images can guide the surgeon as he resects his way through a lesion, showing him residual lesion based on what he's resected. Or he could use IGS to place a shunt using the BrainLab shunt stylet into a very small ventricle, for example, on a pediatric patient, for an example. So ultimately, the surgeon uses all this technology to make more informed decisions for better patient outcomes, better treatments. And where's the future of it going? Well, as mentioned, it's all going to be software driven. Software that can then, I believe, drive robotic technology that can repeatedly perform the same accuracy of targeting that is required for intricate procedures, the ability to place drugs in locations where they're needed, the ability to place therapy where it's needed, ablation type technologies that can be monitored from an MRI scanner that can monitor the ablation of a lesion deep within the brain and monitor temperatures, and that patients can be treated within these technologies. This is going to be the future of IGS, and so the demand on, as we mentioned, will grow on these digital environments, and they'll become ultimately completely reliant on this digital technology. So thank you very much for listening, and good luck going forward. Thank you.